Good afternoon, everyone, and welcome to our weekly lunch meeting. Today, I have the pleasure of introducing Dr. Robert Bertram. Dr. Bertram received his medical education from Temple University in Philadelphia for pediatric medicine in 2013. He completed his residency at the Detroit Medical Center in 2016. Dr. Bertram is board certified in pediatric surgery by the American Board of Foot and Ankle Surgery. Dr. Bertram has been with the Admission Healthcare, now SSM, since 2016. Welcome, Dr. Bertram.
Thank you very much. You guys hear me? Is that okay? Too loud? Too perfect? Got one thumbs up, I'll take that. My name is Rob Bertram. I know I've met a few of you here in the room, but for those of you I haven't met, it's nice to be able to introduce myself to you. I don't get around the hospital here. I'm more so down in Camelot, so to see some new faces is always good. So thank you for having me. Excited to be here. Hopefully I can teach you a little bit something here about foot and ankle injuries in regards to sports or athletic activity. This is a very kind of general topic or general lecture. I'm going to be maybe a little bit too general, but I'd be happy to be a little more specific or answer any questions a little bit more in depth if you guys have any. So a few of the learning objectives here today. Just to be able to identify some common sports, athletic-related injuries as it relates to the foot and ankle. Understand what kind of activities, what kind of sporting events specifically are causing some of these more common injuries. What to look for on physical exam. I know, maybe a lot of you may not be dealing with this, but primary care doctors, a lot of these injuries are seen by primary docs before they get to me. So being able to recognize what's going on and have an idea, and then understand what we can do or what you can educate the patient on to help them prevent some of these issues from from occurring in the future. It's a little comic that I found. I find it kind of funny, but my job is to stop patients before they kind of get to this point. So. This is a slide I really include in all my lectures, no matter what I'm talking about or who I'm talking to. I never really know exactly who I'm talking to, but just to explain what podiatry is. Podiatry is really a specialty, even kind of a subspecialty in a way. Area of medicine, we focus on the foot and ankle, lower extremity issues. If you go back 10, 20, 30 years ago, the training and the education is nothing near where it is today. So podiatrists come a long way. We're able to do a lot more just based off of our education and our training. So the foot and ankle, there's a lot going on. This kind of piggybacks off of that. There's a lot in regards to bones, joints, ligaments, tendons, nerves. We basically deal with anything and everything. So just based off the numbers there, you can imagine there's a lot that could go wrong in the foot. So what am I going to talk about here today? Trying my best to cover as much as I can in a short amount of time. This is a list of things that we'll try and gloss over real quick. Chronic leg pain is a general term. It kind of encompasses a few different things. Sever's disease is kind of the one pediatric related issue as far as athletic activity and injuries go. Stress fractures and fractures in general. I'm not going to cover a whole lot of it, but we do see a lot of fractures related to sports. Bunions are a very common thing just in the everyday patient, but sometimes bunions can cause issues as it relates to sports or limit people from participating in sports. So I'll talk about that real briefly. And then I'll kind of focus in on some more common things or more athletic specific injuries in regards to heel pain or plantar fasciitis, ankle sprains, as well as tendinitis and tendon ruptures. So what is chronic leg pain? I know it's kind of a general term. It encompasses a few different things, like I said. People who kind of have this label when it comes to sports or athletic activities, really are probably dealing with the top three things there. The first three things that kind of encompasses anywhere from 75 to 80% of this chronic leg pain. The first thing is chronic exertional compartment syndrome. This is compartment syndrome, just like we could see anywhere else, trauma. But for this, this is an exertional thing, so increased activity causing increased compartment pressures, which limits tissue perfusion. People are going to have this pretty significant pain that kind of comes on with more activity. It goes away as activity is resolved or is limited, but it's something that you don't really see a lot of, but it should be something on your differential diagnosis. Treatment options for this are really basically limiting your activity, letting things calm down, and if you can, try and convince the patient to not do as much or not do whatever they're doing that brought this on. Worst case scenario, there is surgical intervention. It's a fasciotomy to release that compartment. This issue is really kind of dealing with the front or the anterior aspect of your leg, the muscles within the anterior compartment as well as the lateral compartment. Medial tibial stress syndrome, this is more commonly known to really all of us as shin splints. It's more of an inflammation of the periosteum of the distal aspect of your tibia, more so on the medial aspect of the leg. This is, again, pretty much similar to the compartment syndrome as far as how it presents. Increased activity, improper warming up, improper stretching, that sort of thing, and kind of just getting right into whatever sport or activity you're doing kind of brings this on and is limited if you can reduce the activity or whatever it is that brought it on. There are some things that predispose you to this. This is most commonly it's like a foot deformity, either a high arched foot or a collapsed pronated foot. A limb length discrepancy sometimes contributes to this. But you're basically treating the symptoms, you're letting everything calm down, then you're addressing the underlying issue of improper preparation for whatever sporting event or activity brought this on. Stress fractures, again, this is actually a pretty common thing. They're very often missed, I feel. A lot of stress fractures happen in the tibia and the fibula in regards to the leg. In the foot, it's more so the heel or your calcaneal bone, the metatarsal bones. I'll get into that a little bit more in a later slide. Calf strains, commonly known as tennis leg. This was thought to be due to a tear in a small tendon in the back of your leg, the plantaris tendon. It's really not that. It's more so of a strain or a tear of your bigger calf muscles, your gastroc muscles, or your soleus muscles. Again, treatment or presentation is very similar to the above mentioned issues, and your treatment is essentially the same too. It's resting, it's icing, limiting the activity, letting everything calm down, and then addressing the underlying issue. Really, in this case, a lack of stretching issue. Nerve entrapment syndrome is very, I'm not going to say very rare, but rare. This is kind of similar to a compartment syndrome presentation. Increased activity causing neuritic type pain, burning, tingling, numbness, electrical type pain. Most commonly, or the times that I have seen it, it is the superficial peroneal nerve, so on the front anterior aspect of the leg, or really anterior aspect of the ankle. Tarsal tunnel syndrome is more of a common thing you see in the everyday person, not necessarily an athlete, but it presents similar as far as the neuritic pain. Again, you're treating things initially, the symptoms, letting everything calm down. You can, there's a lot of anti-inflammatories, just modifications in activity, shoes, all that stuff. Worst case scenario, you do get to a surgical intervention to kind of release the surrounding tissue. If anyone has any questions, I'd be happy to answer them during the lecture or definitely afterwards. So, Sever's disease, or also known as calcaneal apophysitis. The incidence is reported to be about 3.7 every 1,000 people. I would probably tend to argue it's a little bit more than that, just based off of what I see. I actually see what I feel is a lot more of that. It's equal in regards to male to female. It's dependent on age. It's usually roughly this 8 to 14 year old active kid who is participating in activity, has this increased pain, swelling, discomfort to the posterior aspect of the heel. That pain then resolves, goes away almost completely with resolution of the activity. So once they stop, things go away. Once they continue the activity, things come back. It's a traction, kind of impaction, injury, irritation, inflammation really within the apophysis, the posterior aspect of the calcaneus. Patients will have pain with medial to lateral squeeze. They're almost like a walking textbook. They'll tell you everything that fits this issue, mostly in regards to the pain with activity that resolves with limiting that activity. Rice treatment is your best option. Worst case scenario, put a kid in a cast for a while, let everything settle down. Anti-inflammatory, stretching, sometimes a heel lift is needed just to take tension off of really that Achilles tendon, which inserts into the back of the heel. But the good news is that this is a self-limiting thing. Once kids mature, that apophysis closes, and you don't have this issue anymore. So stress fractures, I touched on this briefly, they're very common. There's a somewhat recent paper out that talked about 111 track athletes, men, women, like 30s to 40s. They found that within a year span, up to 21% of those people will develop a stress fracture in their leg or in their foot. So it is more common, I think, than what you realize. Like I said, it is the most common usually in the tibia, the fibula, as far as the leg. In the foot, you're looking at the heel, the calcaneus, or the metatarsal bones. It's an abnormal repetitive load on bone causing imbalance of the bone resorption over the formation. Presentation-wise, you get this focal swelling, pinpoint pain, tenderness, really right over the area of the stress fracture. The risk factors, there are a lot of risk factors for this. It's usually, from a biomechanical standpoint, it's a limb length discrepancy. People with a high arched or a cavus foot, they're just inherently putting more pressure through the plantar aspect, the bottom of their forefoot. That puts more stress and strain through your metatarsal bones, these long narrow bones right here, leading to stress fracture. There are metabolic issues, obviously, that predispose you to fractures. The big thing to pick up on this or to take away is that if someone comes in, clinically they're going to have pain. Radiographically, you don't see changes on a radiograph really anywhere up to 10 to 21 days. So someone may come in and describe everything that would fit a stress fracture, but they don't have anything on radiograph. So you kind of just send them on their way, the pain worsens, and then they end up right back to you. So if you get an x-ray really within that first week, 10 days, they may not show anything. Just to be aware that things could be brewing in there. Fractures, dislocations, I could talk all day on this, but I just threw up two common fractures that we see that are usually related to some type of injury or athletic injury or sporting event. The two pictures on the left are a Jones fracture. That's a fracture of your fifth metatarsal base. It's pretty common, I would say. The issue is that these injuries, it's the same mechanism of injury as like an ankle sprain. So a patient may come in and say, hey, I sprained my ankle. You're like, okay, well, here's an ankle brace, or here's a boot, or limit your activity, whatever. This is probably, or could be going on underneath if you don't get an x-ray. So commonly what's done, or what we do from a surgical standpoint, as you can see, we just kind of put a screw right through the bone. You're stabilizing that fracture and waiting for it to heal. Ankle fractures are a very common injury too. Ankle fractures are usually a rotational injury, so a planted foot or a weight-bearing ankle, a weight-bearing foot. And then some sort of rotational injury leads to a fracture. So This would be obvious, on presentation, but we do see this somewhat commonly in athletes. So just briefly, I'm not going to sit here all day and talk about bunions. I could. Bunions aren't necessarily an athletic injury, or they're not a result of an athletic issue. What they do cause is actually limitation in athletic activity. So someone has a bad bunion, whatever they're trying to do, sport-wise, athletic-wise, they may be limited just because of the fact that they have this deformity, okay? So they try and play through it, or just battle through it. What ends up happening though is you just kind of exacerbate the pain, the swelling associated with the deformity. And eventually, if the bunion's bad enough, it'll just get to a point where they can't participate in anything because of the deformity. So again, it's not an injury or a result of an injury from sports or athletics, but sometimes you have to address it so that people can continue to be active, continue to participate in whatever they're looking to participate in. It's a lateral deviation. Bunion is just kind of a general layman's term. It's lateral deviation of your great toe. You get this hypertrophy or prominence on the medial aspect of the great toe joint. That's what people know as a bunion. There's a lot of different ways to treat this, both conservatively, try and do everything you can, different padding or strappings, taping, accommodative shoes, a wider shoe. I mean, people have a foot that's this wide and they're wearing a shoe that's this wide. Well, sometimes just changing the shoe helps a little bit. If it's a sport that involves like a boot or a skate, I mean, you run into even more issues that way. So sometimes you do, like I said, you do have to treat this surgically to just fix the deformity, allow people to get back into their activity more comfortably. This is just an example. Probably 20 or 30 different ways from a surgical standpoint to fix a bunion. It all depends on the severity. This was actually a 22-year-old kid who's very active. He was a D3 basketball player. Just kind of battled through the first few years of college basketball. Finally got to a point where he couldn't play his last year, so we did surgery. I did surgery to give him something better as far as alignment. You can see the angle between the first metatarsal and the second, and then after surgery, the reduction of the deformity. Able to wear a shoe a lot more comfortably, so sometimes you do have to address this. Sesamoiditis and turf toe. This is kind of a general term as well. It's really just inflammation of the plantar aspect of your great toe joint. The anatomy at the bottom, or the plantar aspect of your great toe, is complex. There's a lot going on. You have two sesamoid bones. There's a lot of ligaments. There's a lot of tendons that pass through there. So any irritation to that complex of tissues is really limiting. The majority of your weight is transferred through your big toe. If you have an issue, whether it's swelling or just some incongruity of the joint or whatever is going on, it can lead to a lot of issues, swelling, sesamoiditis, turf toe. Turf toe is more of a hyperextension or a hyper dorsiflexion type injury. You can see this is common actually in dancers, ballet dancers, football players. You commonly see this. But you can see, I mean, this would be an x-ray of a dancer kind of on point. So they're putting all of their pressure right through the bottom, or really the plantar aspect of their forefoot, leads to this issue. So you try and do everything you can conservatively. This is actually called the dancer's pad, okay? So what it does is it just redistributes or offloads the bottom of that big toe, kind of redistributing some of the pressure, the forces, taking pressure off of those sesamoids to relieve things. The picture on the right is a way to tape your toe. What you're doing is you're taping it into a more plantar flex position. Again, this just takes pressure and stress off of that plantar aspect of the joint, thereby relieving some of that inflammation. So plantar fasciitis, this is a very big topic. Again, I could sit here and talk for hours just on this. not necessarily an athletic injury or athletic, related issue, but you do commonly see it in people who are kind of all of a sudden becoming active again or participating in a little bit more activity than what they normally would. It is the most common cause of heel pain in adults. It is kind of a repetitive issue, so the more active you are, like I said, the more stress you're really kind of putting through the plantar aspect of your foot. What do you see on exam or signs and symptoms wise? People, again, this is kind of like a walking textbook. People will tell you I have pinpoint pain right to the plantar aspect of their heel. The pain is worse with first few steps out of bed, first few steps after being immobilized or sitting down. Kind of goes away. The more I go throughout my day, the more active I am, the more this pain comes back. Very common, I'll see 7, 8, 9 people a day with this. The good news is that there's a lot to do for it. I just kind of throw everything at people and see what sticks. And eventually things do get better. I would say probably 85, 90, 95% of people will get better really with a combination of those conservative treatment options that you see there. The biggest issue is stretching, or the biggest issue is the lack of ability to stretch. So the tightness really within the plantar fascia on the bottom of your heel, as well as the tightness within the Achilles tendon, which runs down the back of your leg. They're both kind of the deforming forces or contributing issue. So if you can stretch those tissues out, ultimately what you're doing is relieving the tension and the stress at the bottom of the heel here. Some of your other common things, anti-inflammatories, it's an inflammation issue there. So if you can tolerate those, or patients can tolerate those, that's kind of a go-to. But ultimately stretching is the #1 thing in my opinion. Shoes, orthotics, orthotic arch supports are crucial. What they're doing is they're taking tension and stress off this area as well. Really, there's, like I said, 85 to 95% of people respond to these things in some form. Worst case scenario, those 2 to 5% of people who don't respond, and this takes time or is really over the course of a few months, they do go on to surgical treatment, but it is rare. A few things that I just wanted to touch on other than kind of just the basic conservative treatment options that I have listed there. There's kind of been this push towards platelet-rich plasma injections in the last few years. I have tried it. This is anecdotal, but I do feel that it does help. I haven't done enough of it to really say that definitively, but I have seen some improvement with the use of this. But there has been a push within the last few years. It's kind of dying down, I would say. But there are papers out there that are kind of 50-50, I would say, as far as, yes, this is beneficial, no, this is not beneficial. This was a recent paper that came out a few years ago. It was a double-blind study. Patients were divided into 3 groups. Your typical corticosteroid injection group, which is a common, kind of a mainstay treatment of PRP group, as well as a placebo group. They basically were comparing the visual analog scale, pain scale, and the AOFAS, that's American Orthopedic Foot and Ankle Society scoring system. They did this before the injection, 3 weeks, 3 months. And what they found was that with the PRP, there was a statistically significant improvement. But there was also a significant improvement in the steroid group as well. They did say that there was a little bit more of an increased improvement in the PRP between the two, though. And then same thing for the AOFAS score. So again, I'm not trying to show a bias, but there's more papers out there that support PRP. There's also papers out there that say there's no real improvement. This is probably a newer, or probably a more, has taken the place of PRP, I guess, as far as popularity within recent years, shockwave therapy. What you're looking for is to, basically create a inflammatory, response in this area. You create this inflammatory response, you're looking for new blood vessels to kind of incorporate into this chronically diseased tissue. This was a paper that actually just came out this month, looking at shockwave therapy in comparison to corticosteroid injections. It was a decent study. They had 97 people that were divided into the shockwave group as well as the steroid group. What they were doing was comparing the thickness of the tissue, the plantar fascia. The more chronic your plantar fasciitis is, the thicker that tissue becomes. So they're looking at the thickness of that as well as the pain scale. They did this before 4 weeks and 12 weeks after. And what they found was that pain was actually better at the 4th and the 12th week with shockwave therapy. And what was kind of interesting actually was that they found that the shockwave therapy increased the thickness of the plantar fascia. It's kind of counterintuitive, but they found a positive correlation between the thickness of the plantar fascia and improvement as far as pain. Again, this is, I would say that this is probably 50-50 as well, as far as papers out there that support it, papers out there that don't really support it or say that it has no additional benefit. So lateral ankle sprains, super common. There's documentation out there that 30% of all sports injuries are a lateral ankle sprain. So what do I mean by that? It's really a plantar flexion and an inversion injury. I'm sure we've all sprained our ankle in here at least at one point. I don't know if anyone is into golf here, but the Masters is going on this week. There's a golfer yesterday who hit a hole-in-one, started celebrating, was running up and down, actually had an ankle sprain, actually dislocated their ankle. So he, at least the last I heard, is not golfing this week in the Masters because of what happened yesterday. So there's video out there if you want to look at it. It's pretty interesting. But again, very common. What do I mean by the lateral ankle? I mean, it's really a complex of ligaments, really 3 ligaments. The one right here is your anterior talofibular ligament. This one is your calcaneal fibular ligament. The third one is your posterior talofibular ligament. When you sprain your ankle, when you have a lateral ankle sprain, these ligaments are always damaged in the same order, okay? This is always the first ligament to get damaged, almost always in a lateral ankle sprain. This is the second. About 50% of the time that'll be damaged as well. This is the third one that is rarely damaged. But it is very common. Like I said, there's papers out there talking about 2 million acute lateral ankle sprains in the US per year, which probably is accurate. The big thing to take away from this is that conservative treatment is your best option, okay? You very rarely are you bringing someone to the operating room in an acute setting after an acute injury. The only people that I can think of that you would do this on would be like your high energy professional athlete who needs to get back to activity, or it's their job. They got to get back to it as soon as they can. Conservative treatment really is dependent on how bad things are. You're looking to immobilize or let everything settle down. So whether that's swelling or bruising, pain, you can do this really with a boot, worst case scenario, a cast, but you're looking for everything to settle down. Once everything is settled down, there's this push now to get people back into activity almost right away, or as soon as possible. So instead of immobilizing someone for 6 weeks or 8 weeks, where you get stiffness, you get muscle atrophy, you get weakness, which limits your ability to get back into activity then. The push is to kind of be aggressive with this rehab. Once they're able to kind of tolerate weight bearing, you get them into that. Once they're able to tolerate kind of like a structured rehab, physical therapy program, you want to get them into that as well. So clinical exam, I mean, I think we've all probably seen an ankle sprain or seen our own ankle after we've sprained it. You're going to have that swelling, that bruising. You're going to have that subjective or even objective instability, inability to ambulate, pain really right over that area that I showed you of this anterior talofibular ligament. Maybe you have pain over here. But from an objective standpoint, or really an imaging standpoint, these are two x-rays of an acute sprain. What happens is, on this left picture is an AP x-ray. What's happening is because of the ligament tear that probably occurred, you have increased, this is called talar tilt. So the talus, the bone that sits within the ankle, has this increased ability to invert instead of sitting congruently within the ankle joint. This is this right picture is a anterior drawer test of the ankle. So similar to a knee with like an ACL injury, you do an anterior drawer. You can do an anterior drawer for your ankle. Essentially, what your foot is doing is moving anteriorly. This is the talus that should sit kind of more posteriorly back here underneath the tibia. High ankle sprain, this is a totally different thing. It's the same mechanism of injury. It's usually a plantar flexion inversion injury. But like its name implies, it is a higher or more proximal injury. The lateral ankle sprains that I just talked about, that ligament or that main ligament, the first ligament that gets damaged goes from here to here. A high ankle sprain really is involving the more proximal ligaments. This is one of them anteriorly, but also the syndesmosis. So the syndesmosis is a band of tissue connecting the tibia and the fibula. A high ankle sprain is also known as a syndesmotic sprain. It is more debilitating. People are often out longer. It does cause further instability, requires further rehab or extended period of time before they're back to activity. It's reported to be 1 to 16% of all ankle sprains. Similar presentation, like I said, as far as pain, bruising, swelling, but it's going to be a little bit more proximal in comparison to the lateral ankle sprains. Your treatment, really the same thing for this from a conservative standpoint. You're immobilizing the patient, you're letting everything calm down, the bruising, the swelling, the pain. Once everything is calmed down or calmed down enough that the patient can tolerate weight bearing, you get them back into weight bearing as fast as you can, and you get them into more of an aggressive rehab protocol as soon as you can. Sometimes though, if the instability is too much or there's just frank instability that won't resolve on its own, you do have to proceed with surgery. That is really one of the few ways of doing that. This is a picture, or a set of pictures on the left, is what you would see in a syndesmotic injury. So the syndesmosis kind of runs through here. There's ligaments that run transversely right here. Those ligaments are compromised. You get this gapping between the tibia and the fibula. You get gapping of the medial or inside part of your ankle joint. So that will just inherently lead to more instability if you don't really address it. From a surgical standpoint, like I said, there's a few ways to do that. This is still a very accepted way, although I wouldn't say that many people are doing it like this anymore as far as putting plates and screws in. But you can see kind of the reduction, getting that ankle joint back into proper alignment, or the ankle mortise back into proper alignment, holding it there with screws. This is probably a more common way these days. Same concept, same idea, but as far as what you're trying to do, reducing that diastasis and holding it in place with these suture buttons. 2 buttons on each side, suture in between kind of pulls everything together. You tighten it down and then you're back into a rehab program, eventually back into your activity. Tendinitis and tendinosis, again, pretty broad topic. I'll try and be as brief as I can or hit the main points, but acute, more of an acute issue versus a chronic issue. It's really degeneration of the tendinous fibers. Tendinitis, you don't necessarily see or appreciate that focal inflammation within the tendon, although it's there. That's more obvious in a chronic issue or a tendinosis issue, where you get these palpable bulbous areas of swelling within the tendon. Obviously, this can happen to any tendon in the body, and in the foot and the ankle, it is most commonly the Achilles tendon, but it can also happen on the peroneal tendons on the lateral aspect of your foot or ankle, as well as the posterior tibial tendon that runs kind of through the medial aspect of your foot and ankle. Presentation, again, similar to any other tendinitis or issue, musculoskeletal wise. Aching, stiffness, exacerbation of this pain with activity. Things maybe will go away if you limit your activity, but there's usually that focal area of pain with or without the swelling on exam. Treatment-wise, what are you doing? Again, this is pretty similar to everything else that I covered. RICE, resting ice compression. Really your best bet, you're looking again for things to settle down, resolve, and then you get back to a point where you can address the underlying issue. Most commonly what it is again, tightness within the Achilles tendon, so you're looking at stretching exercises that are really eccentric, eccentric stretching exercises. There's plenty of papers out there that talk about the eccentric mechanism of stretching producing better results versus the concentric stretching exercises. You're looking at accommodating the underlying issue. Sometimes people with flat feet or a pronated foot, they inherently or biomechanically put more stress through their Achilles tendon, which can lead to this issue. So if you address that with an arch support or an orthotic, shoes, sometimes a heel lift, you can address the underlying issue, limit the chance of this coming back. And again, this is more of a, as far as shockwave therapy versus PRP, another area that's kind of being studied as far as these different modalities. Lastly, this is Achilles tendon ruptures, a pretty rare injury in general, but it's a bad injury. You know, I wouldn't wish this upon my worst enemy. It's a tough thing to deal with. It's a tough thing to treat. It's not common, like I said, but unfortunately, we do see enough of it. What is it? It's a rupture of the Achilles tendon. That is your strongest and largest tendon in your body. 18 out of 100,000 people per year apparently have this injury to some degree, whether it's a complete or a partial tear. It tends to be more prevalent in the males as opposed to females. Ages 30 to 40, it's your weekend warrior type people who all of a sudden decide that, hey, I'm going to go do this because I was good at this in high school, so I'll still be good and everything will be good. They don't stretch, they don't do everything they probably should do, and all of a sudden, boom, you get this, oftentimes this audible snap or a popping in the back of your leg. This is very common, like soccer players, really basketball players are the most common. You'll hear people go up for a layup, or basketball players, they'll say they'll go up for a layup. All of a sudden you hear this big pop or this loud snap in the back of your leg. They think they get hit by someone or kicked. They look behind them and no one's there, right? So it is rather common in that subset of people. Presentation-wise or exam-wise, a positive Thompson's test. When you squeeze the calf and you don't get that active plantar flexion like you would on the contralateral side. You do feel, commonly, more so in a full, complete rupture, you do feel a palpable gap, so you'll feel some incongruity within the tendon, and that's in this watershed area. The watershed area is an area about 4 centimeters proximal to the insertion site. Just inherently, it's the weakest part of the tendon. It really has to do with the vascularity of the tendon, so that's the weakest part just due to the vascular, or not compromise, but lack of blood flow to that area of the tendon. Years ago, there was probably a push to treat this stuff, surgically. Basically, taking this end and reapproximating it to the other end, tying things together, boom, they're on their way. There's a big push the other way currently. There's papers out there that say, there's papers out there that talk about conservative treatment, basically immobilizing the person, putting them in a cast, which I'll show a picture of, over the course of several weeks. Conservative treatment being just as good as surgical treatment in regards to muscle strength or regaining that muscle strength. The only drawback to conservative treatment is that there is a higher re-rupture rate in comparison to surgical intervention. People have kind of gotten away from surgery just because of the complications associated with it. There's a lot of wound dehiscence just because of, the blood flow issue to that part of the leg is not the best. Wound dehiscence infection, there's your sural nerve runs right through this area, so people were commonly getting neuritis or neuritic type issues due to damage to that nerve. So, again, the only benefit really these days is that surgical intervention, in theory, limits or decreases your chances for a re-rupture rate.
Room 405.
The picture here on the left is a picture of conservative treatment. So what it is it's this gravity equinus casting. So progressively you put someone in a cast with their foot plantar flex like this, have them come back in a few weeks, you kind of decrease this angle, okay? You bring their foot up and progressively with serial casting, you get them back to a point where they're essentially at 90 degrees. Pictures on the right are just general, surgical techniques as far as reapproximating the two tendons. There's a lot of different other ways to do this. There is a push also, somewhat recent I would say, in acute ruptures that you're going to treat surgically. There's a percutaneous approach that does kind of decrease some of those complications that I just talked about, but those ruptures you have to catch really within the first few days to have a good outcome in doing that technique. So just to end, I kind of threw 2 case studies together here real quick. This was a lady that I'm still seeing. Currently, she 42-year-old, healthy. She's running just recreationally just to kind of stay in shape for many years really, and all of a sudden she decides, hey, I want to do a full marathon. So she kind of picks things up a little bit as far as her activity and her training. She's healthy. She showed up in my office like 7-8 days after this onset of pain. She was having kind of focal pain, swelling right over the dorsal aspect of her foot. It was pinpoint. You pressed in one spot and boom, that was it. So we got x-rays, and those x-rays are here on the left, okay? She was having pain kind of right in this area, okay? So this was 8-9 days after the onset of her pain, right? Radiologist, this was actually ordered by the primary doc. She shows up to see me, radiologist reads it as nothing, because there really is nothing there. But her story just kind of clinically correlates with the concern for a stress fracture. So I put her in a boot, say, hey, stay off of it, stop doing what you're doing. She shows back in 3 weeks or 3 weeks after onset, and boom, all of a sudden you see this callus formation here on an x-ray. So it kind of confirms that stress fracture idea. Like I said, people may not show, or these changes may not show up, anywhere from 10 to 21 days in regards to radiographs for stress fracture. Oh, sorry. This was 6 weeks after her onset, so you can see there's even more callus. bony callus, bone remodeling, bone healing. She's currently like 8 weeks out from when she initially presented. She's back to walking in a shoe. She's not running yet, but she's back to walking without a boot, which is all she really cares about right now. This was a 28-year-old male. He was, at the time, a current podiatry student, Fond du Lac native. He graduated from UW-Madison. He was at a wedding for his roommate. Those of you familiar with Wisconsin football, they play jump around song. So everyone's jumping around at the wedding on the dance floor, and he comes down and he lands on someone else's foot. He has a plantar flexion inversion injury. There's immediate pain, immediate swelling, bruising, almost instant inability to walk or put weight on the foot and ankle. He's healthy. You can see a physical exam there. He's, stubborn. He's probably not going to do what you want him to do, despite what he may know through his education. This is me, by the way. So this is a picture, but I'm going to see if I can pull up a video. So what this is that anterior drug test that I was showing you. You can see how much motion is occurring with my ankle kind of pulling up, and then this is like a talar tilt or that increased inversion. That hurt. That really hurt. So I put myself in a boot for 4 weeks until things calmed down enough, and then I actually did a physical therapy or rehab kind of on my own. The good news was I did get x-rays. I didn't actually break a bone, surprisingly. Most definitely, I'm sure I tore that ATFL, that anterior talofibular ligament, and probably the CFL, that calcaneal fibular ligament as well. So surprisingly, I don't have any instability in my ankle today, but I was definitely lucky. So you can get any presentation as far as these ankle sprains go. You would think that this would be a lot more as far as broken bones or instability, but I was lucky. So that is all I have for you. I know this is a tough topic or a tough lecture for me to give. It's a very generalized topic or general. It's hard to cover all this and not be general, but if anyone has questions, I'd be happy to be a little bit more specific as far as any of these issues and what can be done to treat them.
With
Yes,
stress
sir.
fracture, do you ever do MRIs or bone scans to verify that, or you just?
I do, but it's in the people who are not progressing with kind of the standard approach, immobilization, boot, you can have a stress fracture that doesn't necessarily show up like that one I just showed with the obvious bone callus. I mean, it's very subtle. And if people aren't getting better, or, maybe I've missed it, then I will. I'll do a bone scan. I really don't do an MRI unless there's really maybe something else going on that I'm not sure about. But there's other things too. If people aren't responding to just kind of basic treatment, there's bone stimulators or external bone stimulators that I commonly use. And then if people really aren't responding, then I really kind of get into like a metabolic workup and figure out, hey, what's going on? Is there a deficiency or a insufficiency somewhere that is causing the lack of progression or the lack of healing? But I do get advanced imaging sometimes, yeah.